Hello. Let's discuss adrenocortical insufficiency. Primary adrenal insufficiency is very easy to differentiate from secondary and tertiary. Primary adrenal insufficiency is because there's a problem with the adrenal glands themselves, and so you are going to see a high blood ACTH in an effort to stimulate those adrenals to pump out more cortisol, aldosterone, and androgens. Now, secondary adrenal insufficiency is due to a pituitary problem. So do you think you'll see high ACTH there? No way. You're going to see a low ACTH there, and same for tertiary. That means you don't have CRH, which comes from the hypothalamus, which is what you need to make ACTH in the pituitary. So very high adrenocorticotropic hormone in primary adrenal insufficiency, very low in other causes. I doubt you will get asked about secondary and tertiary because the differential is that easy. Instead, I think you will get asked about the etiologies or the root causes of primary adrenal insufficiency, which is also known as Addison disease. So Addison disease means that your body is not making a lot of cortisol, and so you're going to see a hypoglycemia there. And because you also are not making your mineralocorticoid aldosterone, patients will have hypotensive spells. This might present initially as orthostatic hypotension that just gets worse and worse and worse with each episode. And patients finally have this characteristic bronzing of the skin. That's hyperpigmentation due to an elevated melanocyte stimulating hormone, which, as you know, is generated from proopiomelanocortin. Whenever you make adrenocorticotropic hormone, you also make a little bit of MSH. So the most common cause of Addison disease, which is primary adrenal insufficiency, is going to be autoimmune in origin. And the way that this section of the SDL is set up, we talk about 5 acquired causes of Addison disease, and then we talk about 4 hereditary causes of Addison disease. And so my brain goes, all right, well, acquired causes right there, A through E, and then familial causes right here, A through D, those are your answer choices. Those are 2 questions to me in my mind. That's how I'm treating them. So autoimmune is most common, and it's due to mutations in the autoimmune regulator gene, which we recognize from the Treg development pathway. Adrenal hemorrhage is another cause of Addison disease, and adrenal hemorrhage is going to be secondary usually to septicemia, which means you have bacteria in your bloodstream. So how could you get an adrenal hemorrhage? Essentially, you get a clot and hydrostatic pressure builds up behind the clot in the arterial circuit, and then that high hydrostatic pressure is going to push fluid into the tissues of the adrenals and push blood into the fluid of the adrenals, aided by the fact that there's going to be a lot of inflammation, inflammatory cytokines like interleukins and TNF-alpha that are creating a leaky endothelium and allowing for an exudate, which means blood is just going to go straight through. So I want to recap that one more time if I didn't make it too clear. The most common cause of an adrenal hemorrhage is disease somewhere on the continuum of sepsis, which goes from sepsis to severe sepsis to septic shock to DIC to MODS, multiple organ dysfunction syndrome. And what's going on here is that you have bacteria in your bloodstream. And when you have bacteria in your bloodstream, you are very prone to clotting because cytokines released by bacteria upregulate tissue factor in the wall of vascular endothelium, which is going to generate factor 2A thrombin, which is going to activate factor 1 fibrinogen into fibrin. So fibrin is a component of all clots, and platelets like to stick to fibrin, and so do red blood cells and venous clots. And so the more fibrin you have, according to the more inflammatory cytokines you have, according to the more bacteria you have, the more prone you will be to clot somewhere in your adrenal vein. And so here's the clot in your adrenal vein. What's going to happen to our adrenal artery in this circumstance? Well, blood is going to start to leak out of the adrenal artery as hydrostatic pressure builds and builds and builds, and there is no way for it to go forward due to the presence of this thrombus, and so that's how you would get an adrenal hemorrhage. And a particular variant of that is called Waterhouse-Friderichsen syndrome, which is associated with Neisseria meningitidis infection. We will cover that a little bit later in this text. Infections. Tuberculosis is accountable for about 1 in 10 cases of Addison disease worldwide. And it's actually, not 1 in 10, 1 in 20 here in America, I'd say, but worldwide, TB is actually the most common cause of Addison disease. So understand TB has a respiratory transmission, and then it just kind of creeps into your bloodstream because it's a pretty mobile little dude with a lot of different virulence factors like sulfatides and interesting glycolipid membrane with what do they got? Mycolic acids, correct? And so TB is a slippery bug, and it just gets into the bloodstream, swims on down to the adrenals, which have very small arteries and veins, and there it just kind of intravassates into the tissue and sets up shop. And so you might see a caseating granuloma that is particular to tuberculosis infection in the setting of TB-mediated Addison disease. Now, a bilateral adrenal metastasis, pretty rare, but it could give you Addison disease just by virtue of crowding out the zona glomerulosa and fasciculata and reticularis. And so you're going to have less and less and less production of things like aldosterone, cortisol, and androgens as that tumor exerts more and more and more of a mass effect. And then a final cause, acquired cause of Addison disease is going to be infiltrative disease. And infiltrative disease means that you have a disease involving the accumulation of a foreign substance within the tissues of the body. And so a good go-to example of that is going to be hemochromatosis, in which you have iron accumulating in the liver. Remember that Prussian blue stain. Or possibly amyloidosis, in which beta amyloid can accumulate in several target tissues, for example, the heart, causing a restrictive cardiomyopathy. So now let's talk about inherited causes of Addison's disease. I want you to connect. Whenever we say primary adrenal insufficiency, we are referring to Addison's disease. That's an umbrella term that encompasses all of these etiologies. And I also want to remind you one more time, though, by far the most common cause of Addison disease is autoimmunity. So inherited causes. Congenital adrenal hyperplasia could give you an adrenal insufficiency. And so why? Well, because you've got an enzyme deficiency, and if you don't have this 21-hydroxylase enzyme, then you're not going to be able to make aldosterone, and you're not going to be able to make cortisol. And so you're going to have poor retention of salt, so hypotension, and then you're also going to have hypoglycemia due to that lack of the typical glucocorticoid cortisol. And 11-hydroxylase might also give you Addison disease due to the lack of cortisol there. Same with 17, actually. You would not have cortisol in that scenario too. So all three causes of congenital adrenal hyperplasia can throw you into Addison disease. Then we talk about adrenoleukodystrophy, which is an important disease to recognize, if not for any other reason than that lay people know absolutely nothing about this disease. It's a big, long word with a lot of syllables, and so they will look at you as a doctor and say, "Doctor, what is this?" So adreno, that means adrenal glands. Leuko, that means white. That's referring to the propensity of this disease to involve the white matter of the central nervous system. And dystrophy means improper growth. And so why does this involve the white matter of the central nervous system? Well, because this is a problem in the degradation of very long-chain fatty acids due to the ABCD1 gene, mutations in that gene on the X chromosome. And so because this is an X-linked recessive disease, this presents in male children at a very young point in life. And so you are missing an enzyme that is required for the breakdown of very long chain fatty acids, which occurs in the peroxisome. So this is a peroxisomal disorder. And when you can't get rid of these long chain fatty acids, they accumulate in very particular tissues. And the ones that are the most predisposed to accumulation of these fatty acids are going to be your adrenal glands, your testes, it's X-linked, remember, and finally myelin sheaths by oligodendrocytes or Schwann cells. And so obviously white matter is white matter because of all the fat there. It's optically white whenever you look at it grossly. So you will see symptoms of demyelination, including ataxia, gait imbalance, lower limb weakness, just straight up muscle weakness, maybe loss of deep tendon reflexes. And so that's the hallmark of this disease. You will also see adrenal insufficiency, meaning that these patients need to be on replacement cortisol, replacement aldosterone very often. And the only real treatment for adrenoleukodystrophy that we know of right now is a bone marrow transplant early on in life. And so you are also going to be immunosuppressing these patients to the moon and back. and it actually does result in a lot of fatalities in the teenage years and in the 20s if it's not properly treated early on. Another familial cause of Addison disease, adrenal hypoplasia congenita. So we just mentioned congenital adrenal hyperplasia, but this is the opposite. Hyperplasia means you got big swollen adrenals because you're throwing a ton of ACTH at it. But hypoplasia, well, when that's congenital, what that means is that you can throw all the ACTH in the world that you want on it, but it's not going to grow. So even though you have this high ACTH, the adrenal glands are shrunken. And then there's another symptom that's going to help you differentiate this from the hyperplasia of the adrenal glands, which is going to be a normal degree of adrenal androgen secretion. So recall that in 11 and 21 hydroxylase deficiency, androgen secretion is actually up because all the pregnenolone that you make via desmolase from cholesterol just gets shunted down to your 17 keto steroids, your DHEA, you know. And then if you have a 17 hydroxylase deficiency, on the other hand, you would have absolutely no androgens at all, you know, and so that would present with males who failed to develop male sex characteristics at puberty, you know. And so this hypoplasia of the adrenal glands, androgens are totally fine. Nothing's wrong with them. That's how you're making the differential. Understand that this is X-linked recessive like adrenoleukodystrophy, and that it involves this DAX1 protein and the NR0B1 gene. I think that you are not going to get asked anything about this, but if you do, your brain, your memory is good enough to where you will just pull this out of the back of your head without having to study it or memorize it or anything. Finally, the last inherited cause of Addison disease I want to talk about, familial glucocorticoid deficiency. This is autosomal recessive, and it's essentially an end organ unresponsiveness to adrenocorticotropic hormone, kind of analogously to nephrogenic diabetes insipidus. So you have inactivating mutations in the ACTH receptor, and the proper scientific name for that is going to be MC2R, coded by the MRAP gene. So again, once more, you just look at this once right now, you look at it once on test day, and it's like, okay, I don't need to memorize that. I have a good memory, you know, YouTube. So lab diagnosis, you've got normal plasma renin, normal plasma aldosterone. Why? Well, because this is glucocorticoid deficiency. And even though you have a low degree of ACTH pinging your adrenal glands, well, aldosterone really isn't beholden to ACTH anyway for its production. It's far more dependent on angiotensin 2. So even though, let's say you have 5% or 2% ACTH stimulating activity on the adrenals, your cortisol is going to be way down, but your aldosterone, you will have enough aldosterone to be able to maintain blood pressure. Because besides aldosterone, there are a couple of 17 this and that's, you know, that have weak mineralocorticoid activities, that one deoxycort or whatever, you know. So you've got a totally normal blood pressure in this scenario. So now we start to talk about pathogenesis. Well, essentially, something's taking your adrenal gland out of the picture. Typically, it's autoimmune, can be an infection that is going to lead to hemorrhage and bleeding. And so then if you just get blood pooling in your adrenals, it's going to go hypoxic ischemic, right? And so it's going to eventually just die because it can't get rid of its own waste due to these clots in the venous system. And then we also talked about a variety of familial inherited enzymatic in nature diseases that would just rob your adrenals of their proper function. Once more, elevated ACTH in all of these cases, because that's what your pituitary does when it sees no cortisol in the blood. Once more, symptoms of hypocortisolemia, low blood glucose, it's gluconeogenic. Low blood pressure, it upregulates alpha-1 adrenergic receptors that are going to vasoconstrict you peripherally. Orthostatic hypertension, because it also upregulates alpha-2 adrenergic receptors that mediate the central nervous system efferent arm of the baroreflex. And so if you lose your alpha-2s there, then you're not going to be able to send a sympathetic signal to get your blood pressure up when it needs to be, such as when you stand up from rest. Adrenal insufficiency during critical illness. Transient hypoadrenalism. Inability to mount an adequate and appropriate cortisol response to overwhelming stress or sepsis. This is frequently encountered in ICUs, and this substantially increases the risk of death during acute illness. So we don't quite understand why the adrenals go away in the setting of such severe stress. Maybe they're just overworked and they just can't do it anymore. You know, it's like, how long can you study in a row before you're like tap out, you know, like Birdman? And then it's like, they're also causing these clots. If you have an infection, ICU, huge correlate with an infection, you know, it's like the p-value on that, or the r squared on that, is like a 0.7, you know, it's like a strong correlation. And so it's like, yeah, all these patients have infections, so they might have sepsis or something, and it's like that can give you clots and then lead to an adrenal hemorrhage like we just talked about. So early on, serum cortisol spikes. Of course it does. They're in the stress response, and then it seems to burn itself out. And then CRH and ACTH are suppressed somehow. Maybe TNF alpha, maybe neutrophil-derived alpha defensins are playing a role in the suppression of that adrenocorticotropic hormone. And then obviously without ACTH, you're not going to get much cortisol out of the adrenals. So now we're talking about how to tell these diseases apart, which is not the most important thing in the world, because I mean, some of these presentations are so different from one another. Now, if you've got autoimmune adrenalitis, what do you think you'll see on histology? Lymphocytes. Yes. It's like, yes, let's go. So if you have TB, what do you think you'll see on histology? Caseating necrosis. Yes, you got it. 2 for 2. So if you've got metastatic carcinoma, what do you think you'll see on histology? A stupid high degree of atypia and bizarre nuclei, right? So it's like, hey, 3 for 3. Easy now, easy. So what do these patients look like symptomatically? Well, we talked a little about cortisol deficiency. One more time, cortisol is gluconeogenic. You don't have cortisol, you got low blood glucose. Cortisol will upregulate your alpha-1 and alpha-2 adrenergic receptors, which serve to raise your blood pressure. So if you don't have those alpha-1s, then your diastolic blood pressure will drop and your systolic will drop subsequently. Now, it's also got weak mineralocorticoid activity, but then in Addison disease, you don't have very much aldosterone as well. And so if you don't have aldosterone, then you've got a hyponatremia, a hyperkalemia, a metabolic acidosis, because aldosterone upregulates the proton ATPase from alpha intercalated cells and pops protons out into the tubular lumen of the kidney in exchange for pulling the sodium in. So if you're not pulling sodium in with ENaC and you're not sending a proton out, you got a lot of protons in the blood, and that's the aldosterone mediated, or rather the metabolic acidosis mediated by an aldosterone deficiency. There we go. And finally, bronzing of the skin, tanning of the skin, darkening of the skin can be focal or diffuse, and it's due to the melanocyte stimulating hormone that comes alongside ACTH. Very frequent on the gums and along the skin creases, lines of the hand, maybe of the belly. Few people got those. So can see GI symptoms, vomiting, upset pain, or upset stomach, diarrhea. Might see cardiovascular symptoms, hypotension, very common. You don't have any aldosterone, you're not pulling sodium in at the collecting gut. But also that orthostatic hypotension, one more time, cortisol is going to, when it's there, upregulate alpha adrenergic activity. And so what adrenergic receptor is on neurons, at their synapses? And that's the alpha-2 receptor. And that alpha-2 receptor sends sympathetic signals. And so your baroreceptor, well, the afferent part of that's your vagus nerve, right? That wraps around your aorta. But then your efferent part of that is your brain going out to your blood vessels saying, vasoconstrict, get more blood to the heart. So if you can't send that signal out to your peripheral capillaries and arterioles, well, then you're not going to get blood back to your heart. So there's your orthostatic hypotension with dizziness. Reproductive symptoms due to loss of adrenal androgen production. So you won't see any symptoms related to androgens in men because we have, most of us, 2 testicles, some of us 1, some of us none, but hey, that's all right, you know. So women are going to see decreased axillary and pubic hair, so they only really have hair in that distribution because of their testosterone and their androgens, and it'll start falling out if you have an androgen deficiency somehow. Vitiligo, vitiligo, however you say that. That's what it looks like. This is autoimmune destruction of melanocytes. I'm thinking block 7 for that. Don't go too deep into that right now. That's probably a skin, derm type of deal. So what do our lab panels look like? Well, I'd probably, if I were the teacher, ask you a question about the symptoms, and I would probably also ask you a question about normal lab physiology, because, I mean, you got to know what aldosterone does by this point. So if you don't have aldosterone, again, hyponatremia, hyperkalemia, metabolic acidosis. And so would you get a hyper or a hypocalcemia with that? Well, you would get a symptoms of a hypercalcemia, so slow reflexes, because more protons would be competing with calcium for binding spots on albumin, as opposed to an alkalosis, which has less protons in the blood. So you'd see symptoms of hypocalcemia, like tetany there. Renin activity is elevated in Addison disease because of a lack of aldosterone, causing hyponatremia, therefore hypovolemia. Remember, renin, macula densa cells down in the kidney are going to talk to the JGA, and they're going to get renin pumped out, all depending upon blood osmolarity. And so if you're not reabsorbing sodium, that osmolarity is going to go down. Now we get to diagnosis of primary, secondary adrenal insufficiency. So the first thing you want to do is say, does this patient have adrenal insufficiency? That's a pretty handy question to confirm. You know, you don't just want to run in there and then get smoked by the wrong diagnosis. So you can check serum cortisol concentration, and it'll be negligible if the patient really does have adrenal insufficiency. And if it's kind of normal, you're like, okay, maybe it's not adrenal insufficiency. And you can also do an ACTH stimulation test. And recall that in patients with primary adrenal insufficiency, they've got a lot of ACTH floating around anyways. And so the stimulation test says, all right, just stick me with some ACTH, doc, and let's see if I make cortisol. And so a normal response means you make some cortisol. And then an abnormal response means that you have primary adrenal insufficiency because you've got a lot of ACTH, but you're still not making cortisol. So easy test there, intuitive. You can also give them some insulin to see if they'll make cortisol when their blood sugar gets low. Again, it's gluconeogenic. Or you can do the metyrapone test. Metyrapone blocks cortisol synthesis by inhibiting 11-beta-hydroxylase. And this ought to stimulate ACTH secretion and then drive cortisol back up after the metyrapone clears out of the body. So you give metyrapone at midnight, and then you measure cortisol and 11-deoxycortisol afterwards. A normal response is an increase in serum 11-deoxycortisol to above 7 mg per deciliter. Levels that are under that are diagnostic of adrenal insufficiency. I'm going to have to read that again. That just doesn't make that much sense to me right now. So after you say, yes, patient has primary adrenal insufficiency, or rather, patient has an adrenal problem, then you want to say, is it primary or secondary? And this couldn't be any easier. You take the blood ACTH first thing in the morning, and it's going to be high if it's primary, and it's going to be low if it's secondary or tertiary. And then you want to say, after you figure out it's primary, well, which of the 9 etiologies covered in this SDL are we dealing with right now? Remembering that autoimmune is the most common, so an antibody test is going to be your first call. Might want to get a CT if the antibodies are negative, because then things like TB, tumor, hyperplasia, hypoplasia are going to be on your differential. So in autoimmune Addison disease, the adrenal glands are usually atrophic. They're not there. And how do we treat Addison disease, well, you got to give them hydrocortisone, prednisone, something like that, which is basically cortisol. Then you got to give fludrocortisone, which is replacement aldosterone. So getting those glucocorticoids, mineralocorticoids back into the system is our primary goal of therapy. Now we talk about acute adrenal insufficiency. This is a big deal. Patient's going to have a refractory hypotension because no cortisol whatsoever, no aldosterone, right? Typically, adrenal crisis is secondary to something a lot bigger than that, like a car crash or a very bad life-threatening infection, or maybe they just got out of cardiothoracic surgery, or maybe they were in a fire, they got burned. So adrenal crisis, very common, secondary to those things. So if you're the real badass doc who just can't wait to work with, you know, the sickest, most injured patients, then you need to know what adrenal crisis is, because this is the human body's one of our typical responses to being placed under a lot of stress. It just shuts down your adrenals. So might be associated with hemorrhage, Waterhouse-Friderichsen. Both of those are associated themselves with infection. Stress, infection, 2 risk factors. Number 3 is going to be long-term steroid use that you don't taper efficiently. And you remember Dr. Abel's lecture. She's like, taper, 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 taper. She must have said that 20 times. And it's like, we get it. You got to taper these glucocorticoids down, because if you yank them off, you could send the patient into an adrenal crisis because their pituitary is not making any ACTH because they've been taking exogenous cortisol and they haven't had to make any cortisol on their own. So you pull the cortisol out of there and their pituitary is like, I mean, it's going to take a week to make some ACTH, you know? So they're going to be an acute adrenal crisis. Hypotensive shock, big symptom, vomiting is possible, acute abdominal pain, tachycardia, kind of compensatory for the low blood volume, and hyponatremia, dehydration due to losing all those ions plus the low volume. Metabolic acidosis, why? No aldosterone, no ENaC, no proton ATPase, no proton export into the urine. So understand this clinical presentation, because you should be able to tell from the lab values, the preliminary lab values, that this patient's got adrenal shock. Maybe it's due to a hemorrhage. Remember, a hemorrhage, you're going to get a clot in the adrenal vein that's going to cause a big backflow of blood, and so your adrenal arteries are going to swell and swell and swell until they pop like a balloon or an aneurysm or something, right? And so then you got blood all up in your adrenal glands, and they look like this. That is not a nice adrenal gland. That is a blood red adrenal gland. Here we go. We got another picture right here. That is just tragic, yo. I mean, that's just nothing but coagulation. And this is from a case of Waterhouse-Friderichsen syndrome, which again, it correlated with meningitis, and you're going to have this purpuric rash everywhere, and this is what the rash looks like. And the purpleness of this rash is just bleeding, clots forcing bleeding. Remember, we said clot, you get bleeding behind the clot. Then you get all this bleeding in the skin, in the very superficial layers of the dermis, and so that's why you got this rash. So even without an infection, so we said stress, big risk factor for adrenal shock. Even without an infection, you can still clamp down on your adrenal veins and then cause a hemorrhage upstream of the vein, just like you would with a blood clot. And so let's go back to the visual so you can picture this, right? Except in the setting of stress, we are not talking about a blood clot. No, 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 no. We're talking about a massive influx of catecholamines into circulation. So let's put 1 and 1 together. Where are catecholamines produced? The adrenal medulla. So if you make 100 times the normal physiologic release of catecholamines all at once, what is the first blood vessel in the body that's going to see those? And the answer is the adrenal vein. And so when you get a dumb, stupid high amount of catecholamines, it essentially does the same thing as a blood clot, just through vasoconstriction. It just gets those alpha 1s and it pulls them so tight that it is as though you have a thrombus in your adrenal vein. And so then what happens? Well, hydrostatic pressure builds up in the adrenal artery. Blood leaks out. You got some cytokines. You got an exudate. You're going to get ischemic necrosis of that tissue. So that's how you are going to see an adrenal hemorrhage in the setting of stress. It's all related to catecholamines, and it makes sense that you see it in the adrenals because all the catecholamines you will ever make are produced in the adrenal medulla. Big stuff, big stuff. Might not get you a point on this exam, but it will get you a good rotation grade, you know, if you can spit it like that. Waterhouse-Friedrichsen. Meningitis plus a rash. The only thing that's really going to give you a meningitis with this purple, dark maroon, petechial lower extremity rash. Nothing else on your differential for step 1. Neisseria meningitis, treat ceftriaxone, prophylactic rifampicin for close contacts. Secondary and tertiary. Now, if it's secondary, you don't have any ACTH. If it's tertiary, you also don't have any ACTH, but then you don't have any CRH either. And so the pathologies that cause secondary or tertiary should be very, very obvious to you. Pituitary pathology were a couple of our very first SDLs in this entire block. I would like to point out megestrol acetate, which is a progesterone derivative that is used to treat certain metastatic breast cancers. And so progesterone is going to downregulate estrogen, and you know some breast cancers are estrogen responsive, and so that's why we would be giving a progesterone analog. So megestrol acetate has glucocorticoid activity, binds to the cortisol receptor, and as a result may present with Cushingoid features, and its withdrawal might cause secondary adrenal insufficiency. Here's a good recap of primary, secondary, tertiary. We got our glomerulosa reticulata, glomerulosa fasciculata reticular that's making our aldosterone, cortisol, androgens in order. That's about it for this SDL. So a lot of different etiologies. In conclusion, I would ask you about one of the etiologies, probably two. I'd probably ask you about autoimmune, just to make sure you knew it was autoimmune. Maybe like, what do you see on histology? I'd ask you about adrenoleukodystrophy because it's a big fancy doctorly word. There's a whole SDL on adrenal hyperplasia. I wouldn't ask you about that. Probably get asked about some of the symptoms. You know, why do you see this pigmented skin? Although that's a really easy question. Maybe they want to ask you like, why do you see orthostatic hypotension? They're not going to ask you that. Something about the physiology of aldosterone and the lab findings, and then something about the diagnosis. I could definitely see a diagnosis question coming out of this SDL. Thanks very much.